Not on Tobacco program is a well-known and established system and was awarded in 2004 by the Centers for Disease Control and Prevention for being the most creative and innovative concerning deterrence of substance addiction. This program audience was targeted on teenagers who are regular smokers wanting to quit and some who are unable to quit. The primary objective of this program is to reduce and stop tobacco use and smoking cessation and to influence the lives of teenagers positively. Fundamental questions like what are the effects of smoking, who are the affected people, will be vital in trying to help addict group. Social factors, a health determinant. The study was also affected by the interaction between the persons and their physical and social surroundings, that is, their their social and economic environment. For instance, many Americans youths that live in a low socio-economic status, poverty-stricken areas are often introduced to vices like smoking at a very early age as young as 14. As available youth smoking data for 2000, 2002, and 2005 revealed an average West Virginia youth smoking prevalence rate of 33.3%. An implementation of a social peer group training, like training manual among teenagers, was observed to be helpful training in quitting smoking. However, NOT programs significantly reduced smoking among the youth involved. It was well received by teenagers and facilitators and benefited participants in the other areas of their lives like healthy activities, stress management, and attendance in schools. The program incorporated American youth, both smokers and non-smokers of all genders, from many schools from different school districts. They all had different backgrounds with varied perspectives on what smoking was about. The program tackled many topics like motivation, preparing to quit, and relapse prevention with a follow-up survey, and facilitator confirmed it was helpful. To improve the diversity and diverse perspectives of the participants, the discussion in the program were delivered in same-sex group of up to 12 teenagers and were led by a same-sex facilitator. This was to make the participants comfortable to speak out about a myriad of issues that concern them and ask questions, especially for those who may have been shy. The NOT program addressed public health priorities of community by increasing focus on the impact of a teenager smoking on family and community, such as health risks for family members, youth promotion, inclusion of activities, tobacco use rates and health consequences, and living a tobacco-free lifestyle. Source shows smoking prevalence of 24% among 12th grade students. Among students who do not plan to attend a four-year college, the prevalence is 36%. This will help inform participants about the risks and effects of tobacco smoking and nicotine addiction, as the health benefits that came with quitting the habit far outweigh the habit itself. Ultimately, cases like respiratory conditions, cardiovascular diseases, and cancer and level of smoking greatly reduced. Infrastructure. The key players who were part of Not on Tobacco program included the members themselves, all the authors, public health professionals on tobacco, the Center for Disease Control and Prevention, National Cancer Institute, American Lung Association, counseling professionals, and other community members that included the teenagers from rural and non-rural youth, investigation group, and the local counties, facilitators who assisted in designing and promoting the program's activities. For example, some teenagers were grouped into smoking groups and non-smoking groups. Posts were posted around the school compound and other issued to students. There were billboards, media campaign, telephone follow-up, and self-help brochure was available to the public. The program facilitators went around schools, communities, to set up training facilities and address tobacco risk behavior and related diseases. The main objective was to reach out to students in the school communities. For example, the West Virginia and North Carolina schools. Same-sex group and same-sex facilitator were created. An example is a 10 hours long session on average of 1 week was observed and student-teacher ratio, geographic location, economic status, low-income counties, and smoking prevalence of the community or county of the school were considered. The external stakeholders were the parents, families, and friends of the youth, the community, local counties. They were involved because some teenagers who smoke either learned that from parents or friends. For example, participants observed smoking more often among friends to be 98.4%, that parents 78.5%, and siblings 60%. Facilitators wanted teenagers to quit the habit while ensuring that the non-smokers would not engage in smoking. The state's involvement was mainly due to economic reasons. Becoming addicted to any substance, including nicotine, means that you rely on it a great deal. The addict eventually resort to violent methods to acquire that which they crave for. No smokers who are unemployed and are addicts offer little to no contribution to build the nation. Community resources that were used to develop and implement the program included the schools in the city that were used to host the meetings for the program and the posters and flyers made by the community members to spread awareness about the program. The community members were also involved in the program. They put in their time and effort to ensure the smooth running of the program and offering their input through suggestions on how to improve the project to maximize its impact in the society. This program funding was supported by Center for Disease Control and Prevention, the Department of Education in West Virginia and North Carolina, the National Office of the American Lung Association, and the American Lung Association in Florida, National Cancer Institute, Robert Wood Johnson Foundation, local counties, state, communities, not-on-profit, master settlement agreement, also a great source and impact. For example, they prohibit tobacco promotional program. Delivery. In my own opinion, to market not program to a community which include teens, parents and families and school teachers, I would carry out research on the subject matter and the prevalence rate in the target community to know how much effort will be required, who will be the participants, funding and the financial cost the program will incur. Having this information beforehand will then enable me to figure out what marketing campaign to use. The important information I will convey to get the community to buy in the NOT program is by informing them of the benefits that would come with the program, such as increased productivity in the society, improved economic standards, reduction in tobacco smoking related complications, example, lung infections, better health conditions, performance of the said community's youth, and improvement in the general living standards of the member of the community. I would educate them on the dangers of tobacco smoking and nicotine addiction, its side effects like high cases of lung diseases and addiction. I would then bring to their attention a few cases cited educational materials on the effects of nicotine addiction present in their community to reveal how important it is to fight and prevent such incidents from repeating themselves in the near and far future. No community would want to associate with any of that negativity. Therefore, it's imperative to involve the members in the transformation process to make them feel like part of the initiative. This I will do by requesting them for their input on how they would want the program to be run, delegating some duties to them, like spreading awareness about the program, hosting the program in all access places such as community centers or churches. I would also try to incorporate songs and any other cultural activities that they enjoy doing to capture their attention. Moreover, I would use effective and appealing language in communicating with them to buy in the NOT program. Qualities and ethics. Some of the identified ethical concerns in tobacco prevention and control (NOT) program are to achieve community health with respect to rights of individuals, addressing fundamental health effects, aim to prevent adverse effects, develop programs with input from the community, implement effective and acceptable tobacco cessation program, ensuring a competent workforce, inform and obtain consent of communities for program implementation, establish a self-help intervention, and observe quit rate progression. Many adolescents are lured into cigarette smoking, usually through their peers, parents, and siblings, and are unable to fully conceive the health impacts they will later experience. For example, data showed participants observed smoking more often among friends, 98.4%, than parents, 78.5%, and siblings, 60%. Thus, it is reasonable not to underestimate public health perspective in terms of its potential impact to intervene in reducing or controlling tobacco health hazards through intervention or program that will benefit communities. High smoking rate and difficulty with cessation gave rise to rural youth cessation programs. Topics such as tobacco growing economies, favorable tobacco environment, favorable norms about use, geographic isolation and lack of access to services, cultural and traditional values and customs, poverty and stress and coping. A public health ethical approach is to examine how the application of each intervention can influence tobacco control program. An ethical concern to promote a tobacco-free healthy community, which are also conveyed and supported by major funding organizations such as Robert Wood Johnson Foundation, National Cancer Institute, and the Center for Disease Control and Prevention, the American Lung Association, Not on Tobacco program. The efficacy of this program showed a high quit rate, as was observed at the end of 3 and 6 month follow-up, estimated at 11% and 22%. More so, a 4-year study from smokers between the ages of 12 and 19 years had a successful quit rate of 15.6% per year. Participant adherence was measured by participants' completion of baseline and post-program evaluation. Facilitators and school administrators were informed that participation was voluntary. Participants also obtained signed parental consent and signed an assent form before program enrollment, and approximately 90% were study eligible. The opponents in this program are the teen attrition and some facilitators. Major discrepancies were found between the numbers of total trained facilitators and those actively offering the NOT program. For instance, 664 total facilitators were trained from 2000 to 2005. Only 96 facilitators actively offered the NOT program during this period. Teen attrition issues constrain the program by teens not being present for reasons beyond their control, such as moving out of the state and/or graduation. An informed parental consent that is required also discourages minority participation because it warrants further investigation. There were economic, political, and social factors that contributed to the development of this program. These factors led to need to assess tobacco-related economic and political climate in rural tobacco growing areas, the risk of smoking in teenagers and its effect on their behavioral lifestyle contributed to NOT program development. Economically, NOT is suitable, adoptable, and a cost-effective program. More so, youth from less educated, impoverished rural area, low-income counties had fewer cessation programs and are noted as high-risk smokers. These factors contributed to a competent workforce to the development of this program. A match design was used based on the race, economic status, school team population of participants in the program development. This was a potential collaborative effort and relationship that supports community in the development of this program. Conclusion. In conclusion, there was high quit rate and smoking cessation was effective. Some of the reasons that made this program successful are that NOT demonstrated respectable effectiveness on maintenance and the overall dissemination was fruitful, showing a high quit rate. Cooperation from the programs was excellent, although there were inherent limitations. It was also successful because participants of NOT showed a positive and sustained smoking behavior change, and this suggests that NOT can be effective teen smoking cessation option. The negative effect of my short-term program initiative will have impact on not being able to reach out to larger community or not being able to incorporate larger number of teen smokers in the program, as such not giving a quality participant turnout. On the other hand, this will positively have an impact by studying effectively a smaller group participant. However, the positive effect of my long-term program initiative will have impact on increased quit rate and may pose a negative impact on teen attrition considering the length of time it will take. A typical manifestation of this was observed on a 4-year study which found smokers between the ages of 12 and 19 years had a successful quit rate of 15.6% or approximately 4% per year, as opposed to the Appalachian of 15 months intervention with less quit rate. Since NOT program was effective and fruitful in the rural area where there is less fund, low education, more teen smokers, I would say it is a scalable program to replicate, enlarge, and extend to accommodate any community.